Love this podcast? Support it and sponsor today. Simply head to ozcastnetwork.com for details.
Thank you for downloading and listening to This Pathological Life. If you're interested in continuing the story, we have a second series called This Medical Life. Please download it and subscribe now.
Dr. Travis Brown, why do we need a podcast called This Pathological Life?
Every disease has its own story to tell. So we're going to tell them.
Dr. Travis Brown, COVID-19 is still with us.
It is. I'm hoping we might be able to conclude it by season 3, maybe.
However, I popped in to get a coffee before we came here at a place nearby where there's a supermarket, and a bloke walked in, not checking in, nothing, just completely. And this is how I've changed. I stared at him.
Well, I remember you asking me in sort of season 1, so episode 2, season 1, we said, will we ever be the same? And it's just like, we have very short memories. Right at the moment, it feels like it's all-encompassing, because it is. But we will go back to our old ways very quickly when things settle down. And this is, the name of this episode is Covidity. This is actually mixing two terms. So COVID and avidity. And avidity is a test we use to test the strength of an antibody and an antigen reaction. And look, I thought it was fitting because COVID has tested the strength of nations. It's, around the world you can actually look at, and just by sheer numbers, you get a feel of how do they manage. And some are encouraging and some are honestly devastating.
Well, I was expecting the other word was going to be morbidity.
Yep. Yeah, and look, it is, it's just, how do you describe being in the middle of a pandemic? I think we've been very fortunate here in Australia. Politically, we've had pretty much most of our politicians on the same page. There was a discussion about it, being a suppression approach as opposed to an elimination approach. It's pretty much gone to an elimination approach. And to be honest, I think that's fantastic. I think the governments deserve, Australian government, state and federal, should be congratulated for that.
Yep. Been a hard slog, and it's the sort of thing where politicians have had to step up and be real again, and actually do real politics, as opposed to, I feel we got to a point where there was just the usual cut and thrust and the sideshow of politics. But real decisions had to be made that were affecting people immediately.
And so, there's been a few grumbles along the way, and each state has managed their own. But to be honest, when we look at the world, these numbers are from, yesterday. So, when we record this on the 28th, so this is from the 27th of January 2021. Unfortunately, the number of worldwide infections have just clicked over greater than 100 million. And we've got around 2.16 million deaths. Now, mortality is just such a crude measure, and this is because it doesn't take into consideration morbidity and the impact that it has at a societal level. But, things like a patient who gets unwell, has to go to hospital, goes to ICU, but fortunately recovers, is not covered in mortality. That's a significant burden on the patient, their family, a hospital bed, an ICU bed. It's not measured in there. So it's a rather crude measure, but it still is a measure, and it tells you that if a large mortality rate, generally you can assume that there's been a significant morbidity rate, a larger one, a cost of that to that society for those people who have died. So it gives us an indication of the severity. If we accept the limitations of mortality, let's look at the highest deaths per million. And so this gives us a comparable ratio between countries. And so unfortunately, the worst at the moment is Belgium. That has a death rate of 1,800 deaths per million. So their population size is 11 million people. Now, one of the useful measures here is in the last 7 days, how many deaths have they had per million, and theirs is at 27. So that's low comparatively to what I'll discuss now. But We have Slovenia at number 2 with a death rate of 1,600 per million. They have a population of 2 million people, but their last 7 days is 74 per million. So still in the middle range, to be honest. The surprising ones, honestly, is the UK. It has a death rate of 1,460 per million with a population of 67 million. But their death rate the last 7 days is 120 per million. So that's, when we're using the 7-day ratio, that's only second to Portugal, which has a 7-day death rate of 140 people per million. So you can see, even though we haven't mentioned Portugal, Portugal's last week has been bad. The United States has 1,270 per million. So they have a population of 328 million, and their 7-day death rate is 61 per million. So again, to put that in context, you almost have to look at the lowest death rates per million. So these are countries like Burundi, Vietnam, Thailand, all of which have death rates per million overall between 0.1 and 1 per million. So they haven't had, essentially, these next countries that I mentioned will have had 0 deaths in the past 7 days per million. That includes China, who has a population of 1.4 billion. So China has a death rate of 3.4 per million overall. So they've gotten on top of it, but we have seen some of the tactics they've used to do that. I don't know if any democratic societies are able to do those techniques. But then we look at places like Singapore, which have a death rate of 5 per million and a population of 5.7 million. New Zealand, 5 per million as well, around a population of 5 million. Australia sits in at 35 deaths per million, and we have a population of 25 million. So Australia's doing really well. I think we're doing a fantastic job. But there's other countries who have just stomped on it straight away and haven't pretty much almost had hardly any deaths per their population. So you can see the governments have had a huge role in their impact. And unfortunately, it looks like the country that's doing the worst, or looks like they're heading for the worst, is the UK at the moment. So then that tells us, what evidence do we have of how to be able to stop COVID? And so that brings us back to the infectivity rate, so R value, which you'll remember, the reproductive rate. And so, again, everything has a caveat. Everything has there's limitations to limiting a pandemic to a figure, but there are some useful things you can draw out. Now, the rate is, when we look at it, we know the rate of COVID itself has a reproductive rate between 2 and 3. So running by itself, one infection will affect 2 or 3 people and infect those 2 or 3. So just naturally, you'll see an exponential rise in COVID if it's left to its own devices, which will go from 1 to 4, 8.
And beyond.
Yeah. And so if you get your reproductive rate below 1, the epidemic or pandemic will reduce. If it's at 1, it will stay the same. If it's above 1, it will increase. If it's between 1 and 2, it will steadily increase. If it's above 2 to 3, you're in epidemic, pandemic region. So what have we found have had the biggest impacts on the R value? So we know there's been 4 main events that have actually slowed and reduced the R value. School closures and work closures, a ban on public events, stay-at-home orders, and restrictions on internal movements. So individually, these can reduce the R value by between 3 to 25%.
Wow, okay.
When we look at it from effectively trying to reduce it, if we employ school and work closures, stay-at-home orders, a ban on public events, gatherings of less than or equal to 10 people, and restricted movements, you can reduce the R by 52%. So the problem with that, when we look at it, is you say if you have an R value of 2 or 2.5, dropping it by 50% will take you down
to 1.25.
Yeah. So you need it long. So what they've found, but that has to be implemented, and that happens after 28 days. So those have to be in for about a month for it to have a significant effect on the R value. The problem is if your R value is 3, it needs to be longer to get that implementation. Now, that's not taking into account contact tracing and isolation. And also sometimes a lot of governments would say we're going to have restrictions in a week. And so then people would actually have what we would call super spreader events effectively leading up to it, which would increase the R value to then try and reduce it and come back to it, which was counterintuitive, but that's what it is.
Especially the crowding in shops as people started panic buying before the hard lockdown was a classic case in point.
So you're seeing what's happening. This is the information we know now. So what is the transmission? Well, we know it's respiratory droplets. And the most people who are at risk is if you're face-to-face with a person who is infected for 15 minutes within 2 meters. So these are the people who are most at risk of transmitting the infection. Singing and shouting increases the range at which droplet spreads through. So concerts, shouting,
church services,
everything goes through, increases the amount that it will spread.
Yeah.
And it can aerosol in crowds and poorly ventilated areas, spreading it even further. So who's then most at risk for people when they get outside of, super spreader events and large gatherings? It's within households, spouses sleeping in the same room, friends and family gatherings because it's close contact. And so we know that household contacts have about a 4 to 35% chance of getting the infection just by being about. And so high-risk activities, dining in close proximity with people, sharing food, and group activities. But there's other sources of transmission. You can get it in your eye from the conjunctiva, so if someone, you don't just have to breathe, but you can also ingest it, again, sharing food. And there's also now something that seems to be coming out a little bit more, is fecal shedding. So we can do, again, this is how we can test in a population. You can test the sewage and see is COVID in the sewage to say, yes, it is, because people shed more through fecal than respiratory. So now we haven't been able to isolate it and grow it. So we don't know if it's infective. That was yet to be seen. But, it will certainly make our drive-thrus a bit different if we start doing swabs like that. But...
Well, you'd have to get out of the car.
Well, no, just a window. I don't know if that's going to make it. That won't get past Charlie. But we also know that the virus can survive many days on stainless steel, plastic, and glass. It prefers low temperatures and humid environments, things like air-conditioned environments, but it is easily killed or inactivated through household cleaners, surface cleaning, UV, and hand washing. We know a lot about it. We know a lot how to stop it. We know how it spreads. And so, what are the symptoms of people? Well, they get fevers, they get myalgias, headache, respiratory symptoms. And from animal models, we hear a lot about the loss of smell. Well, it seems that COVID has an effect on the olfactory epithelium, so of the nose, as well as the sustentacular cells that support the neurons. And it seems that they have something that will make sense later, ACE2 receptors, that appear to get damaged in some people and take a long time to recover.
Right.
And so that's why they have an inability to smell, is that their neural centers that smell get damaged. And so, again, as I said, the pathogenesis is that the ACE2 receptors on the cells is in respiratory epithelium, so in the lungs. We have it in the intestines. We have it in endothelial cells in the kidney and in blood vessels. So this gives us an idea of where the virus can attach. So who's at risk? Elderly people, people who have cancer, chronic kidney disease, chronic obstructive pulmonary disease, so emphysema, people who have long-term heart conditions such as congestive heart failure, coronary artery disease, or cardiomyopathies, people with type 2 diabetes, obesity, people with sickle cell disease, smokers, and pregnancy. The protection of the society protects all these people, so again, death rates, morbidity, mortality reduce. I think the approach has been the right one for effectively elimination in that. This brings us to, well, what has worked at an individual level. So we know what happens in a societal level, what needs to. Face masks. So now it's unusual because the population now knows about face masks that are the N95, which doctors, who usually would have known about that, microbiologists would have, Now, why is it called N95? Because it filters 95% of airborne particles that are 0.3 micrometers and larger. Now, the interesting thing is that COVID is approximately or around 0.1 micromillimeter. So it could get through it, but it has to travel on droplets. And droplets can be 0.2 micromillimeters. So it still has to get through. So it's not perfect, but it does reduce. The interesting thing is we don't have a great lot of evidence about how useful they are because it's hard to measure. We have good indications that it's useful, but the studies just aren't there to compare, even in this age. And so we know that it reduces the risk of transmission, but it doesn't stop it. So even if you've gone about, it's all these other measures. If you're not doing all these other measures, you will reduce it, but it won't stop.
Hence, your collectors have the masks, the big shields on top of the masks as extra barriers.
We have eye protection, you have masks, you have gowns, you have gloves. You're protecting yourself as much as you can as a healthcare worker. The surgical and cloth masks that people wear, there was an observational study that found it has about a 70% effective at protecting the wearer. So, and again, if we have dual layer sort of cloth masks, they are actually better than the single cloth, as you would expect. Eye protection reduces transmission by about 75%. And so then we're looking at social distancing. How effective is that? Because some countries said 1 metre was enough. Some said 2 metres was better. But again, this was historical. We didn't have data on that. It was that you should stay away. But we did find out, there was a systematic review that found that people in a healthcare environment had a 82% reduction in transmission when they were 1 metre apart. So, and they found that the further you distance, the less risk you have of transmission. So, but again, this didn't take into account airflow, air conditioning, recycled air and filtered air. So again, you start going into one of those areas that the evidence, you can ask a lot of questions, but we don't have data to back it up, but we can draw conclusions.
It'd be interesting to see how many cyclists have picked it up from motorists who are meant to stay a metre away.
You never know. Yeah, as I say, it's just one of the, everyone's seen online those things of the sneeze where it goes everywhere, and and the last one is hand washing. Now, we've known for centuries that this has worked. In fact, Ignaz Semmelweis is a 19th century Hungarian doctor. He was the first to recognise. He was in a hospital which had a physician-based maternity ward and another place which had a midwife-run maternity ward. And he compared the two, and the doctors had a mortality rate of the women between 13 and 18%, whereas the midwives had a mortality rate of 2%. And he looked at it and he said, well, how is there such a disparity? What he ended up finding is that the doctors would do autopsies and dissect cadavers, go straight from there without washing their hands to deliver a baby. And they got this mysterious illness that was called childbed fever and had almost a 1 in 5 mortality rate. And he said, you're not cleaning your hands. Now, he was ridiculed at the time, but eventually shown to be right, that hand washing is essential in reducing transmission of illness and bacteria. And so this brings us to the last point I want to raise here, which was the Sweden experiment. So we had worldwide approach to it. Everyone was locking down, but Sweden said, no, we're actually going to go to a different approach. We're not going to have restrictions. And so they didn't mandate public health measures, public transport or shopping malls or other crowds. They had a recommendation of less than 50 people per gathering. And initially they had seemingly encouraging results. In April, they had a peak death rate of deaths of 102. They dropped to a low in September of 2020, and they even lowered the restrictions there more in October. But then in December of 2020, they had around 780 deaths per million, which was about 4 to 10 times their neighbours. And so they believed that this was due to their lack of restrictions, and they've brought in restrictions now as a measure. So they've sort of moved away from that herd immunity, let it do its course, and that brings us to sort of the global view of where we are with COVID in the start of January 2021.
All right. Before we bring Dr. Daman to the podcast, I'm going to go and wash my hands. You do it too. So, Travis, we've got that background with COVID-19. What do we actually know about the virus?
So the virus, what we know, it's an envelope virus. It has spikes, which we will talk about. Again, that's important for vaccinations. It's got a membrane protein. We know the genetic sequence. It is, this corona or the COVID virus is 96% similar to a bat coronavirus named RATG13. There was the SARS outbreak in 2003. This is 80% genetic similar to that SARS virus. A question is, why did that one not become a pandemic, and why did COVID? It turns out it's most likely, what we can think is the peak infectivity period of COVID-19 tends to be when you're becoming symptomatic or pre-symptomatic, and 1 week into your infection is the peak time that you can transmit the virus. For SARS in 2003, the peak infectivity period tended to be week 2 of your infection. So you were already symptomatic at that point in time and not passing it on. So, at this point in time, there's around 4 variants. So you've got the original. There's a UK variant named B117. There's a South African variant named B1351, and Brazil variant named P1. There's a Denmark variant, and I tell you right, in the next few weeks, there's going to be a few more variants just because of the sheer volume of numbers. And so the relevance for us in pathology, why is this important? Well, we need to sequence it to know what it's linked to, where it's come from, but we also need it for the PCR test for our targeting. So if it changes its sequence so much, our target might change, and we might say, oh, it's not there when it is there, but we don't have the right target. So it's something we're monitoring as a pathology organisation. We're looking at it, how long does someone shed for? So shed meaning you've still got viral particles, but you may or may not be infective. So people tend to shed the virus for 17 days, but we know that they can shed it up to 83 days as the longest recorded. But from studies, it seems to be that after about day 9, you tend not to be as infective. So it drops down. So this is why people talk about that 2-week period of isolation, is because sometimes you might be pre-symptomatic, so you not have it, and then you have those 9 days. So 14 days of isolation, you can be still shedding the virus after that, but it's not infective, or virus particles, should I say. So what does that mean? Well, initially the data, we thought it was really high with the asymptomatic rate. It was, anywhere between 40 to 80%. It's somewhere, what we believe now, is probably about 20%. So 1 in 5 people may be true asymptomatic. And what that means is that people who are shedding the virus and sending are pre-symptomatic. So they'll get symptoms. They're not truly asymptomatic for the disease, but they're being tested and positive before they're showing symptoms.
Sure.
So, yeah, the severity with regards to, when someone comes into a hospital, we know if they've got a high fever at presentation, if they're having difficulty breathing, or, even if, general signs like a low systolic pressure less than 100, or high respiratory rate greater than 20, or, even an altered Glasgow coma score, so their, consciousness is altered. These are bad signs for a patient to be coming in. If they've got lab tests like, a neutrophilia or a lymphopenia, a raised lactate or LDH, or, raised CRP, ferritin, ACE2 or a D-dimer, these are all signs, but they're not specific for COVID. It's just general over sort of tests that we do to see how they're going. So, those are general markers. What we do know, though, from autopsies, there's a recent article that's come out from the Archives of Pathology and Laboratory Medicine. They did 135 autopsies on COVID patients, 19 centres across the US and Brazil. And what they found is that most of them had more than one pre-existing condition. So we're talking diabetes, 52% had diabetes, 34% were obese, 64% had hypertension. The interesting thing is 7% of people didn't have any comorbidities. So there's a segment of people who are seemingly well that still can have a fatal outcome because of a COVID infection. The findings from the autopsy are, again, as you would expect, mainly lung damage. So a condition that's a pathological condition called diffuse alveolar damage, 75% had an acute histology of that, and 47% had organizing DAD. 40% had acute bronchopneumonia. And then we've also got some thrombi, so, clots, either macroscopically, about 20%, or 50% had microscopic in the lungs. And interestingly, 77% had what we say the myositis, so cardiac cells were increased in size, but only 6% showed myocarditis, so inflammation of the heart. So that was thought to be something earlier. But when we look at the post-infection complications, there's something called multi-system inflammatory syndrome that can happen in adults and children. Again, this tends to be, rare complications. For adults, it's a few weeks. It depends on where the virus has been and where it's sort of showing that inflammatory disease. And people get worried about children, but it's actually really rare in children. And they're talking about months later. But again, that's being drawn out in the studies. And the only other thing, which is the main complaint of people, is long-term loss of smell and taste. And it turns out about 80% of COVID infections have some sort of disturbance of smell. And that's because the olfactory, so the nasal lining, the epithelium, it appears to be damaged. The cilia gets lost, and some of the supporting cells of the neurons have ACE2 receptor sustentacular cells, and this seems to interfere with that. So people say smell does return after about 6 to 12 months, but that's a known problem that comes through. And aside from that, that's what we know about COVID, the virus itself and symptoms. So
our guest is ready, so let's come back in just a moment and continue the program. Joining us now, we have Dr. Daman Langus, clinical immunologist with Sullivan Nicolaides Pathology.
Thank you very much. Glad to be here.
Thanks, Daman. Look, I was wanting to ask you, there was a significant proportion of discussion last year about the development of COVID vaccines, effectively as a magic bullet for the pandemic. We've got a number that have come out, certainly Pfizer, AstraZeneca, Moderna. Can you tell us the difference or similarities between the different vaccines that have been developed from what we know now as they're being released?
This last year for science and medicine really represents a triumph of the marriage of true science with the commercialization and then delivery of a vaccine to a virus that we've never seen before, and has managed to produce a vaccine to a virus type which we haven't been terribly interested in most of the time, except for these extreme outbreaks, particularly the last SARS and now this one. In fact, not only are the vaccines you will have heard of, there are actually 173 vaccines in clinical trials, in preclinical development, and 64 in clinical trials, and there are 15 in phase 3 development. So there are multiple Chinese vaccines and there are Russian vaccines. Most of those won't be seen in the West, but they really are an incredible array. And they kind of split into 4 groups. The ones that have garnered the most interest, I think, are the mRNA vaccines, because never before have we ever had a clinical vaccine which was an mRNA vaccine. So this really is taking the mRNA sequence. After all, coronavirus is an RNA virus, and it is taking that, inserting it inside a liposome. I saw a great analogy somewhere online which likened mRNA vaccines to an M&M. The mRNA, which is easily degradable, is the chocolate gooey center, and the liposome is that crisp shell. I think I'm using the correct M&M terminology. And that really allows us to deliver this very fragile and easily degradable substance into the human body so we can process it. And that is a reason why the temperatures, specifically with the Pfizer vaccine, have to be so cold. So -70 is a classic temperature at which we keep mRNA. Now, the Moderna vaccine, which is the same technology, only needs -20. Now, we don't know why there is a difference. Moderna is a private company. It's proprietary knowledge about their liposomal construct. We do know that it contains polyethylene glycol, which has been rumoured but probably isn't the cause of any allergic reactions. So those 2 vaccines, and they are the 2 mRNA vaccines that we have. And obviously in Australia, we'll only have the Pfizer vaccine available. Then there are sort of traditional vaccine. That's where we take, in this case, a piece of the virus, so the spike protein in this case, and we stick it in a vaccine. And that might be with an adjuvant, something that promotes immunogenicity. We actually don't know how most adjuvants work. Aluminium's been used for 50 years, and we still don't know the exact mechanism by which it acts as an adjuvant, but it's very effective. So the Novavax, which Australia does have capacity to make, is a protein subunit vaccine. And I think the Australian government's ordered on something on the order of greater than 50 million doses. And it's a 2-dose vaccine. So that's, on my reckoning, enough to vaccinate the whole of Australia completely, just with that vaccine alone. And then there are the viral vector vaccines. So that's where another virus, like adenovirus, which is not live, has bits of the coding sequence of DNA of this virus, i.e. COVID, inserted into it. And we use the fact that this construct is stronger, and that's what the AstraZeneca vaccine and the Johnson & Johnson, or Janssen as its drug arm is known, vaccine contains. The interesting thing is, while the AstraZeneca vaccine is 2 doses, it appears in data that's either going to be released or has just been released that the Janssen vaccine is incredibly immunogenic, i.e. most people will make antibodies against it to something like 98% after a single dose. Now, for healthcare delivery, a single dose is so much more immensely attractive. The amount of resources that need to go into getting people to come back for a second dose. Everyone has chaotic lives. Some people way more chaotic than others. We have the tyranny of distance in Australia. Many people live a long way, especially in regional and remote communities, Aboriginal communities. Getting vaccines out to them or getting people to come in for vaccination once is possible, twice is way more difficult. And so if we're looking at blanket coverage to risk groups, it would be lovely to have a one-off vaccine. I'm not sure we're going to get that in Australia, though. And then the 4th type of vaccine is an inactivated virus. Now, none of the vaccines produced by the large Western companies are using this route. This has largely been used by Chinese companies. I think the days of using an activated virus, it's a harder selling point. Like measles, there is a very, very, very small chance that you actually get active infection. And that chance is very small, but it's if you're going to combat vaccine hesitancy, then I think you need to, especially when you have the technology, to be able to use the safest thing possible. So those really are the four types of vaccine that we have available in the whole world. And as yet in Australia, we have two coming, which are the Pfizer mRNA vaccine, which is 2 doses, and the AstraZeneca or Oxford vaccine, which is also 2 doses, which is, of course, a viral vector vaccine.
You just used the word safety before, and I know there was a trial that was ceased in Queensland. Can you tell us a bit more about that?
Sure. So there was actually no problem with safety. In part of this so-called molecular clamp technology, it's basically inventing a protein construct as if like a clamp that you hold a bench to a tool or to a bit of wood. It's a ability to stick various proteins or viruses and attach it on, like clamping it to it. And this technology was hoped to be a way to quickly produce new vaccines to various things. Unfortunately, the protein, well, not unfortunately, but the protein used was a HIV protein. So not HIV, but a protein which originated in HIV. So a single protein called P24. Now, we use that in diagnosis, and that antibodies to P24 are used in the early diagnosis of HIV. They aren't the diagnosis, but they're part of it. And so in pre-human models, I think monkey models, there was no evidence that P24 antibodies were made. And so the study went forward, and unfortunately, a small minority of people who received that vaccine made antibodies towards P24. And this isn't dangerous, but unfortunately, if they had an HIV test, it would make them look like they were positive or early positive to HIV. And obviously, that's not actually a danger to those patients. Nothing's happened to them. But for a long time, it would be very difficult to diagnose HIV in those people.
A lot with the vaccine, they're talking about two different terms, which are very similar. So efficacy and effectiveness. Can you provide some clarity as to, the difference and what impact that has?
Sure. I mean, the two terms are actually completely the same. Yeah. They just apply in different circumstances. Right. So efficacy is really in a controlled trial. Right. So what you're looking at is the number of people who either make a antibody response, and that's usually predetermined. So you've decided what an effective antibody response is going to be, and or lack of severe disease. So in all of the trials, the number of patients who ended up in hospital because of COVID, when they had been vaccinated with almost any of the vaccinations, was either zero or incredibly low. So when we're talking about differences in vaccine strength or antibody titer or the number of people who make a predetermined response, sometimes that doesn't really translate into real world outcomes. Sometimes it's worse, but in this case, it appears to be a great deal better. And even when we're talking about how many people make antibodies, when we say compare that to the seasonal flu vax, if we got 74% coverage for the seasonal flu vax, that's an amazing year. An amazing year. Often, unfortunately, because of the way that virus recombinates, we've been sitting down at like 23%. The worst vaccine, and I say that meaning in the efficacy, not in the actual outcome, in other words, it's still a very good vaccine, is still better than the best year, still better than the best year in flu. So in other words, the AstraZeneca vaccine, they're talking about 75% effectiveness. So that's still better than the flu vax has ever been. We're actually dealing with vaccines that are all incredibly efficacious. Now, when we talk about effectiveness, that's when we translate that into real life. So what actually happens when we take people who are not on a trial basis? These are people who are relatively well, they're mobile, they're able to get to trial centres, they have good use usually of the English language, They are generally not marginalised. They're not isolated. So when we move into the real world, we want to see that when we translate that clinical data, trial data, to the real world, that we see a similar fall in the number of patients with COVID who are hospitalised. And obviously in Australia, that's impossible. We're not going to see any difference because even at our worst, we still didn't have anything near even half or a third of several places in the world. So really, what you'd be looking at is particularly in the UK, where there's relatively good data that when the vaccine is rolled out, you start to see areas where or populations who severe COVID does not occur again.
Talking of real world, in the real world, many GPs listening to this are going to have patients ask them, what are the side effects if I get this vaccine? They may not use the term contraindication, but they'll be asking about side effects. How would you be responding to that and putting that into some sort of context?
Yeah, I think we have to be pretty honest. It's from the studies, it's pretty obvious that these vaccines are very immunogenic. And when I'm talking to my patients, always sell that as saying, your body is making a great immune response. And how it does that is it generates a response similar to when you have an actual infection. So that's how vaccines work. They're tricking your body into thinking they have an infection. They aren't infected, they just have a small part usually, or in this case, the RNA of the virus. We then go through the stages of viral infection of a cell, even though it's not a whole virus. And then our immune responses respond to that. If we didn't actually have that kind of process, we wouldn't make these antibodies. It's pretty clear from the Pfizer trial that 25% of people get a fever with the second dose. So that's much higher than most of the other vaccines we're used to having. I think we have to be realistic. When people are having their second dose, they have to be warned that they may not be able to attend work the next day, that they might feel very unwell, that if they have multiple comorbidities, that they may need to make sure that they have ability to contact either healthcare workers or friends or relatives, not necessarily because they're likely to suffer severe consequences, just so they can be prepared. And in case they were so unwell they couldn't get out of bed, they can be helped through that. It really doesn't appear to last longer than 1 to 2 days in most people. And there are slightly lower rates with the AstraZeneca, with significantly lower rates of fever and muscle pain myalgias. But the mRNA vaccines, probably because they are very immunogenic, they are probably mimicking a real infection more than the other types of vaccine. And the other thing about them is that they generate a true polyclonal response. So viruses aren't very good at producing themselves faithfully. They're very good at reproducing themselves, but they don't really care if they make mistakes. A bit different from a human cell. We really care if we make mistakes because the outcome can be horrendous, either autoimmune disease or cancer or organ dysfunction. Viruses just keep going. And so that means when we're using our cells to help them replicate a small bit of the virus, we actually get lots of types of virus. And so we make a very, very widespread response. And I've always said to people, this is your immune system making a fantastic response. It's a small price to pay to know that you're completely covered against this virus.
Are there any patients that can't receive the vaccine, any contraindications, people who should be warned away from it?
There probably are a few. In my line of work, people who do not have a single B cell, and there are a few of those, and there are some people on drugs. Now, it's not actually going to be harmful for them. They just won't make any response because they lack the cells to make antibodies. In other people, perhaps, and we don't know, that if you are allergic to polyethylene glycol. Now, these people exist. It is a rare allergy. They usually have multi-drug allergy because polyethylene glycol, otherwise known in medications as macrogol, is often in many medications, and they often have multi-drug allergy. But this is very, very rare. We're talking maybe there's 30 people in Australia with that. It's a guess, that number, but it is very rare. I think I've seen one patient in 20 years. But it's only something we've kind of known about for the last 10 years. You will have seen that initial report with the vaccine rollout in the UK where a couple of healthcare workers had anaphylaxis. And there was a lot of work done looking at, could this be PEG allergy? Not the stuff you hang up washing with, but macrogol allergy. And it isn't. And in fact, subsequent analysis has shown that people with a history of allergies are no more likely to react to this vaccine than anybody else. So it really is a random event. And having looked at vaccine anaphylaxis before, you're usually dealing with 1 in 100,000, something like that. And often we never find the cause. So the cause may actually be that single person's immune system just doesn't like that mode of exposure to antigen. That's a bit of an immunologic cop-out. It just means we really don't know.
Okay, so there's a bit of evidence coming out, new strains, new COVID variants, and this has been topical because, as the vaccine's rolling out, everyone's like, well, will it even cover this new variant coming out? Can you give us a little bit more light on this? Is it a large concern? Is it a small concern? Is it something that we need to always keep an eye on?
I think it's a small potential concern that we definitely need to keep an eye on. Most of the time, viruses don't become more pathogenic over time, but this virus has already shown that's not true. So COVID-19, the British variant, appears that the new variant spreads a little bit more, nothing like the media has kind of implied, but it spreads more, but it actually you have a third greater chance of ending up in hospital. So that's kind of unusual. Most viruses decrease their pathogenicity over time. But the fact is we've really only had this virus for a year, so it kind of might behave slightly differently. The vaccines so far still have significant efficacy against them. And there's no reason to think that on a population basis, our vaccination programs would be affected by the present mutations. So when we look at effectiveness, they make less, or you make a lesser degree of antibody response, but it is still enough to give you an immune response. Right. So that when that's put into the real world, it's highly likely that it won't make much difference at all. But given that these variants have arisen, it's going to be something that the whole world has to keep on top of. The best thing is that the 2 mRNA vaccines have the ability to edit the mRNA sequence relatively easily. After all, Moderna had their sequence ready to go within a month of receiving the original sequence. So it didn't take them long. So it's kind of like a drop-in cricket pitch. Yes. So when you do your next match, you can actually just edit your mRNA. And because their technology is so good, by the way, I don't own shares in Moderna, that their technology seems so fantastic, they can drop the next sequence in and then create a second COVID-19 vaccine. So now, obviously, that would take a long time to roll out again, but it's a lot quicker than any technology we've ever had before. So it's certainly something we're going to need to keep an eye on.
So do you think this is almost going down the flu line of each year we'll have to keep an eye on the COVID strain that's coming on through?
I think it's not going to be quite like that because the flu strain has multiple viruses that are recombining in an unusual way, which other viruses do not. So it's the recombination of attachment proteins and other proteins in the flu that the multiple strains are circulating at once and they then recombine, which is why we can lose flu-vax efficacy during a year. This mRNA technology actually gives us the ability to perhaps have 2 flu vaccines a year. Depending on obviously where it is, you can't really make a new vaccine for a relatively small market, and Australia is on a vaccine scale a small market. But certainly you could in the US, and there is a potential to say have a vaccine in January and a vaccine in June, July, and that might increase our efficacy towards flu. I don't think there's any evidence that coronavirus can change like that. So far, its changing has somewhat been interesting, unexpected, but I don't think it'll be able to change to the same degree that the influenza virus can. But it may be that because world herd immunity is not going to be happening this year, I think it would be very unlikely to be happening next year, to be honest. There are a lot of people in a lot of places. There are a lot of good people trying to put a lot of effort in, but realistically, there are, 7 billion people on Earth, and we have to vaccinate them all. So what that means is that the coronavirus might continue to circulate low grade. That does, depending on how it mutates, that does give the potential for it to mutate into something worse. But it also has the potential then to go back towards the common cold end of the spectrum.
On that term of immunity, do we have any sense yet of the long-term immunity that these vaccines might provide, or even the infection itself?
Well, actually, we've got quite a lot of data now. So thank goodness around the world people are collecting this kind of information. We know that natural infection, if you are not immunocompromised, so if you're an average individual, and even in the elderly who have survived COVID, is that they have evidence of persisting immunity for at least 6 months. So that gives some considerable time. And the same for vaccines as well, about 6 months. It appears the vaccines work well in those who have been infected as well. So there are plenty of people who've already been in the US who have had COVID-19, who, because they're in the high-risk groups, are being vaccinated. We know that less than 1% of people with COVID-19 are able to be reinfected so far. So the virus has been around already for over a year, potentially a bit longer, but in decent quantities, at pandemic levels since March. So the reinfection rate is low. In those people, it appears to be a mild disease in the vast majority. And we do not know if the reinfected people are able to spread the virus.
Lastly, there's just the question, which was raised a fair bit, about herd immunity. So you're saying that maybe don't even think it will be probably this year or next year. I mean, is this a realistic discussion to have about herd immunity? Is it something that sort of, to be honest, I don't know a disease that we genuinely have herd immunity just because the percentages have to be so high.
We did have herd immunity to measles before anti-vaxxers got in. Oh, right. Australia has herd immunity to cervical cancer.
Right.
Oh.
Because our rate of cervical cancer now caused by the HPV virus is so low that we have almost induced, well, we probably have induced to those strains the vaccine covers herd immunity.
Right. Okay.
So, that's an incredible thing that we've done, because sensible people get vaccinated to something that can kill young women. And we've gone from a rate of, I don't know what the rate was, to a rate close to zero. We're the closest country on earth to eliminating vaccine strain-inducible cervical cancer.
So then how far do we need to get for coronavirus to fit into that category? I mean, you're talking about a 95%?
Well, no, I think you're kind of getting up to sort of 80, 85%.
Right, okay.
It would be lovely to see Australia get to 95%. I think true vaccine-resistant people are not that common. If you look at it, let's say a microcosm, the NRL last year, when they were told they had to be vaccinated to influenza to be able to play rugby league. Several players expressed doubt and said they wouldn't. When it was pointed out their career was on the line, they got vaccinated. A couple didn't, and they left the country, which is fantastic from my point of view. But talking to my patients, lots of people express doubt, but that's because they haven't had communication.
Yeah.
And all it needs is reassurance, and logical reassurance. You admit that vaccines do cause side effects, no problem. But if you look at the other effects, what's the downside to not being vaccinated? And that's pretty obvious. We've got natural experiments in the UK and the United States. We can see what happens when you stuff things up. And really, I think in Australia, I think the government has a good aim. Even in the UK, the vaccine rollout's going really impressively. They've vaccinated 10 million people already to their first dose. Whether they manage to do the second dose in time, somewhat moot at the moment. But I think Australia does have a good history of vaccine programs. We have a lot of resources, but it is going to be very resource intensive. But I think most importantly, pretty much all business is on board. I can't imagine a hospital or the business that I work for, our pathology companies, you're going to need to be vaccinated. I see patients clinically. If by the end of the year you haven't gone and got your vaccination, you're not going to be my patient because you're not going to be allowed to put my other patients at risk.
Thank you so much, Dr. Daman Langeth, for joining us for this episode. And I will be thinking of you when I go to get my vaccination and asking my GP if I can use your M&M analogy, if I could have the red one, please.
Yeah, don't miss the green now.
Thanks, Daman. Appreciate it.
Bye.
This Pathological Life is produced by ClinPath Pathology in South Australia. Episode notes, references and learning objectives, when applicable, can be found at thispathological.life.com.au. And you can contact the hosts on Twitter via @Dr. Travis Brown or @Steve Davis. Thanks again for listening, and just a reminder, if you haven't done it yet, have a quick search in your podcast app for our second series, This Medical Life. Dr. Travis Brown has rolled up some extra guests, some extra topics, and we continue the story there, and we'd love to have you along.
Love this podcast? Support it and sponsor today. Simply head to AuscastNetwork.com for details.